this webinar today. So Dr. Anupama Gotimola and Dr.
मेरा नाम भूल गए
चक्रवर्ती तुम तो मुझे मार डालोगे तुम्हारा नाम भूल अमित तुम्हें कैसे भूल सकते हैं and I just got distracted, a call came. So anyway, I'll let Dr. Gotimola and Dr. Chakravarti take over the session and line up their speakers and go from there.
Thank you, Seema. Go ahead, Amit.
So first, before we get started, I just want to take 1 minute to, by the way, I'm Amit Chakravarti, who Income Secretary for the API, and I have to announce a disclaimer for the teleconference of COVID-19. The services of API COVID-19 teleconferences is for information purposes only and should not be considered as medical or financial advice. API has no liability as how this is interpreted, no liability for results, losses, damages that may be caused directly or indirectly. Please refer to the CDC website and your state government's health authority for information and updates. So it gives me great pleasure to announce the first speaker of tonight. You all know her. She is the Vice President of API, Anupama Gotimola. She is pediatric anesthesiology at Children's Hospital of San Antonio, and she'll be speaking today on resuming elective surgeries post-COVID-19 pandemic, anesthesiology perspective. As Seema said, today's conference is mostly like, how do we get back? It's called post-COVID renaissance, quandaries and conundrums of getting back to work safely. All of us have to get back to work safely, and we need to find out what's the best way to do it. So here's Anupama. The stage is yours.
Thank you, Amit, for your kind introduction, and thank you, API, for giving this opportunity to me to be the speaker tonight. And good evening to everyone. And so I'm going to talk about, from the anesthesiologist perspective, resuming elective surgeries. So how do we prepare, and what are the considerations if something happens like post-COVID-19 issues, postponing surgeries, and second surge preparation. So what is our primary duty as healthcare worker? First thing, do no harm to our patients and do no harm to our healthcare team members. Protect our presumed healthy patients from potential risk of exposure, and use our resources appropriately. So I want to revisit some dates which are relevant to my topic. And we all know that March 11th, COVID was declared as a pandemic. And March 17th, a week later, CMS released a guidance to limit non-essential adult elective surgery and medical and surgical procedures, including dental procedures. So a month later, on April 18th, these four associations, the American College of Surgeons, ASA, and Perioperative Registered Nurses, and American Association of American Association of Hospitalists, they released a joint statement, the roadmap for resuming elective surgery after COVID-19 pandemic. So I'll walk through the roadmap briefly in these 5 minutes. So first thing is readiness. So we need to have policies and procedures. So anesthesiologist plays a vital role here. He or she is a part of the committee, including the surgeons and the nursing leadership. And so the committee develops a surgery prioritization policy and also adopt informed policies for the 5 phases of surgical, like starting from preoperative to post-op discharge care planning. So these 5 phases will include include the post-COVID issues. Actually, we come across those. And also the committee has to form policies, collect and assess the data to frequently reevaluate and reassess these policies. And implementation of social distancing policy for staff, visitors, patients, etc., in anticipation of second wave of COVID-19. And also testing policy is very important. So timing, how did we start these elective surgeries? So in order to follow the, the policies are formed now, and now we are ready to start the surgery. So first thing is, in the town wherever we live, there should be sustained reduction in the cases for at least 14 days before we resume the electives. And also it should be authorized by the local county and state health authorities. And can the facilities perform keeping in mind patient safety and staff safety? And facility should have appropriate number of ICU, non-ICU beds, ventilators, medications, anesthetics, etc. And also we should have trained and educated staff so that we can do our planned procedures safely. And so in order to start our all these postponed surgeries for last 1 month or 1.5 months, so we need to start in a phased manner. So first thing first, we started with 2 cases, 2 ORs mid-May, and then went up till to 4, and then by mid-June, all the ORs were open. And also we prioritized how to start, so which cases take priority. For example, cancer, organ transplants, or cardiac, they take the priority. And also in my hospital, for example, we took as a three codes, like we have a red and green and yellow. So the red is the one which needs surgery in a week, and the green is like they can wait a month. The yellow is they can wait more than a month. So we faced that way. And also we prepared our the whole entire OR team for these extended hours in case we have to do all these cases pending. Testing policy is very important. When do we test these patients? For example, now it is mandatory that every patient coming in, patient or outpatient, they have to have testing done 48 hours before they come to the OR. And also, if the testing is not available, then we follow the evidence-based infection prevention techniques. And also, we have to use appropriate PPE for all the entire surgical team. And also, the facility should have testing capability if someone comes as positive, like a healthcare worker or a patient. And also protective equipment. So the facility has policies, like the hospitals have their own policies. Every staff member is being trained how to use the PPE properly and how to do the donning and all those. And also conservation of PPE, how do we save, recycle those same N95 masks, for example, and extended reusing the PPE as per the CDC guidelines. So decontamination of these N95 masks or any respirators, every hospital has their own way. So there are several ways. My hospital, we do hydrogen peroxide vaporization, but there are other hospitals you can use steam heat or 77 degrees oven for 30 minutes. So these masks are safe to use up to 10 times. So the N95 I use is recycled 10 times before I throw it away. And we are also anticipating the second wave now. I don't know if we call it second wave or is it the surge of first wave itself, but these are the following things we have to follow, like wear mask. Every healthcare worker in the hospital, it is mandatory to wear a mask, including patients, visitors, etc. And hand sanitization, social distancing all over, everywhere in the hospital. And we also have to follow the regulatory issues formed by the Joint Commission. How do we do the air exchanges and all and how do we clean the anesthesia machines after using on a COVID patient? So these are the things we have to be very careful and follow strictly. So this is a picture of a device. It is a HEPA filtered aerosol hood, courtesy from University of Minnesota. Thank you, Dr. Gulani, for giving me this slide. And this is a device where the patient is on a high flow nasal cannula. So we have to prevent to contaminate the whole room. So this is something which the thing has a HEPA filter, and it will filter the inside aerosol particles, and after filtering, the air, clean air exits to the blower into the room, so which is safe, so the other people will not have that viral load. And also it is very safe to use, and it has active suction, and also one of the best devices right now being in the market now. And so we are all preparing for the second surge already. Now my town has daily 400, 500 cases going on. Today itself, Texas has 5,000 cases just today. So we are all in the code gray now. So this is emergency preparation going on now. So every person has to be tested with a nasal swab test 48 hours before coming to the surgery. And also some electives are postponed, which require post-op admission and ICU admission. And the hospitals are advising staff to come back and return to work. And PPE conservation reprocessing actively going, and student rotations were stopped in some hospitals already, and bed capacity is at the maximum now. So we have to plan very carefully how to come across with this acute thing going on right now in few states in the United States. And universal protocols, community education programs are going intensely. So that's all my presentation. Thank you so much. I'll take the questions if any at the end. Thank you, Amit. Muted. Unmute.
Okay, good. Can you hear me? Yes. So thank you very much for your wonderful talk and keeping on time. We've got a lot of speakers, a lot of wonderful speakers, and I hope we can finish the thing in time, enough time to have question and answers. Please post your question and answers at in the chat box so that we can get to it at the end of the talk. So next, it's a pleasure to introduce to you my dear friend Shripad Dhaulikar. He is an attending orthopedic and spine surgeon at Robert Wood Johnson, Barnabas Health and Hackensack Meridian Health, wow, mouthful, in New Jersey. And he is going to speak on resuming elective surgery during COVID-19, the orthopedic perspective. So we have tried to actually get different perspective of people who are actually the most vulnerable people with COVID, and have them present their perspective. So here is Sripad.
Thank you very much. I just want to have 1 second. Yeah, I want to thank API for giving me this opportunity to present today. And thanks for that kind introduction, Amit. I love to be on this panel. And Anupama has already given a nice basic overview of the whole COVID situation as to when it started and where we are at this point in time. And all of us certainly were, canceling all the surgeries in the past, being prepared for all the emergencies in the hospital. But many states are now reopening, as Anupama mentioned. And as far as New Jersey goes, New Jersey, New York have been the hotbeds of this infection. We've had a lot of cases, a lot of mortalities. And so as of May 26th, the governor issued a directive saying that elective surgeries may be resumed in the state of New Jersey, certainly with many conditions, which I will go over in a few minutes. But although the elective surgeries were resumed a month ago, I can't tell you that the patients have lined up to have surgeries right away, because certainly there is a lot of hesitation in the public still as to whether to have the surgery or not, whether to go to the hospital or not. Even when people have some semi-emergent conditions, they have elected not to go to the hospitals just in the fear of being exposed to COVID. So although the surgeries have started, they haven't quite started in full earnest as we were before COVID days, but hopefully we'll be getting there soon. So mandatory COVID testing for patients is required for all those undergoing elective surgeries. It used to be 48 hours to 72 hours, but now it's prolonged to 96 hours at this point. And once the patient has a COVID test done, within 3-4 days of surgery, we are advising the patients, or the state actually has mandated that the patients actually self-quarantine themselves so that they don't get exposed until they come to the hospital for having the elective surgery done. I've placed a question mark at the next line, COVID testing for surgeons or perioperative staff. This is sort of there's no clear-cut roadmap as far as this goes. So one of the hospitals that I go to is mandating that the surgeons have COVID testing done every 2 weeks if they continue to operate. On the other hand, another system, hospital system that I go to is more or less made it voluntary rather. Obviously, if there are any symptoms present, then that certainly raises the urgency, and then the staff certainly has to get tested if they start to have symptoms. So surgeons as of now are not getting tested mandatorily. It's more or less voluntary, which is certainly appropriate to do so that we don't spread COVID to our patients coming in for surgery as well. Postponing surgical plans during COVID, again, canceling non-emergent surgeries or non-urgent surgeries, again, is still the rule because we don't know if a second wave is likely to hit. Certainly cases in many states have started to rise again. So we need to kind of be prepared for that as well. So those patients who can wait certainly for a few more months to have surgery done electively, then they are being advised to do that. Most of the surgeries, if it's possible to shift them to an outpatient setting, is also a very good idea. A lot of my spine surgery cases, for instance, cervical fusions, discectomies, etc., they're all getting done as an outpatient procedure in a surgery center setting, so they don't get exposed to the hospital, minimize the amount of PPE use. They go home the same day as well. So this way they don't necessarily use up a hospital bed. So minimizing the use of any cleaning supplies, PPEs, beds, etc. in the hospital. It is also advisable to have multiple teams which are completely insulated from each other. That would be the ideal situation. Obviously, it's not possible in every practice. For instance, my practice has about 4 PAs and 1 nurse practitioner, and we have 2 PA stations in the hospital and 2 PAs more in the office. So this way they don't sort of cross-contaminate each other as well. Again, close monitoring of the perioperative team is really very essential. As soon as you start to have any symptoms in any of your perioperative nurses or circulators, it's mandatory that they get tested right away as well, so that we minimize any transmission to the patients themselves. When it comes to operating on the COVID patient, certainly there is a high morbidity and mortality, and only if the benefits of surgery outweigh the risks is surgery gone ahead with. Certainly emergencies such as high-grade open fractures, a necrotizing infection, or a compartment syndrome, these are emergencies that cannot wait no matter what. So even in a COVID positive patient, these have to be done because these are more or less limb-threatening or life-threatening situations that cannot wait. Similarly, there are cases such as displaced femoral neck fracture, periprosthetic joint infection, which if you were to wait for a while, the infection can spread, causing further deterioration of the joint or causing further bacteremia, septicemia, etc. So these have to be addressed in an urgent basis as well. Viruses have been identified in the blood in past epidemics, such as in MERS and also in the COVID-1 infection, which happened in the past. A virus was identified in the blood of patients as well. And being in orthopedics, there's a lot of power tools that we use, such as drills and burrs and reamers, etc., which causes a lot of aerosolization of the blood, from the operative field. So it's very important to protect surrounding staff as well. The limited use of electrocautery is also required, and any fumes that come from the electrocautery use also need to be suctioned right away as well, so that you don't aerosolize that. Many orthopedic surgeons from major centers recently got together and produced this orthopedic forum. This is actually an article which is not yet in print. It's available in electronic format right now. It's going to be printed within the next month or 2. These are actually guidelines, medically necessary orthopedic surgery during COVID-19 pandemic. And they actually came up with a risk stratification or risk classification. And this will be appearing in the Journal of Bone and Joint Surgery very soon. What I like about this classification here is obviously all of us know that the COVID positive cases have a higher risk, no matter what, especially if the patient has some pre-existing condition. And as you can see on the left-hand side here, the classification goes from 1B to 4 with increasing severity, where 4 indicates COVID positive patient with a critical disease. And but the important thing about this classification, the nuance I should share about this classification, is that this takes into account the community prevalence of the COVID infection as well. For instance, you may have a hospital in the Midwest, in South Dakota or somewhere where the cases are very, very minimal. So the community prevalence of the virus itself is very less. In those cases, perhaps you could take more of a risk in going forward with surgery, as opposed to being in New York or New Jersey, where the risk might be significantly higher, even in minimally symptomatic or asymptomatic patients. So this is a very good way to look at it. Class 4 surgery is not advised until the patient is stable, whereas in Class 1B, you can proceed with minimal risk. Postoperative considerations, again, the patients have to minimize the hospital stay for these patients. This way they don't get exposed unnecessarily to hospital environments. Our patients in orthopedics generally require a lot of physical therapy, etc., postoperatively. So it becomes an issue versus having patient get a home physical therapy and or outpatient physical therapy versus inpatient rehab, where many patients get transferred to inpatient rehab facilities such as nursing home, etc., where they recuperate and get stronger before they really go home. But that subjects the patient more to COVID situations once again, whereas the nursing homes, as we know, in the past have been really hotbeds of significant infections going on. So if you can minimize that part of it and send the patient straight home with outpatient or home physical therapy, that's again very much desirable. Monitor the patient again postoperatively for fever, cough, respiratory infections, not only for a postoperative infection standpoint, but also looking for COVID symptoms as well. Mitigation precautions have to be continued, as all of us are continuing to do with the masks and hand washing, etc. So in closing, I'd like to say, wash your hands, but don't wash your hands off of COVID, because we are not quite completely out of the woods as yet. So with that, I'm going to stop. I think my time is running out, but I would be glad to stick around and answer any questions in the next several minutes. Thank you.
Amit, I think you're on mute.
Okay. Thank you, Dr. Dhalikar. That was awesome presentation, and especially giving the perspective from orthopedic standpoint and from the New Jersey standpoint, like you said, is the hotbed. Next, we have our esteemed speaker, Dr. Manoj Jain, MD, MPH. He's a faculty, Rollins School of Public Health, infectious diseases physician, chief medical officer to the mayor of Memphis on COVID-19. So he's ID physician, and he's a chief medical advisor to mayor of Memphis and advises him on reopening status in the city of Memphis. He was a consultant to WHO on tuberculosis and chair of RP-TB committee. So without further ado, Dr. Manoj Jain, and he's going to speak today on topic COVID-19, the science of reopening. Manoj.
So thank you, Amit, and thank you, Anupama and Seema and everyone here. Good evening to you. Everyone will remember COVID. Everyone will remember the summer. My COVID journey began in February 25th. I've known the mayor of Memphis, who's standing between myself and, if you know, Swati Kulkarni, on February 25th. And Swati came to Memphis just for a casual visit. And we went to visit the mayor because I've known him, had done a fundraiser for him at my house, and he'd been there quite some time. For a decade, we've gotten together. And at that time, we conversed about a lot of things, but COVID was there. I had written about it in the paper, but he wasn't very worried until I got a text from him on March 10th. And he said, Manoj, can you come to town hall? And I said, okay. And he said, what time are you coming? He said, what time are you free? And he says, I am free anytime you are. We need to talk. And basically, when I arrived there, the entire executive committee was there. We had everyone from the police chief down to the HR. The room was packed. And we had a 2-hour session, after which there was a come to Jesus thought process that we are in trouble.
Manoj, we need to finish in about another 5 minutes. Thanks.
Yeah. So just to say, how did we think and how do we talk about COVID? It's really to think about it in terms of the following 3 steps. First, think about it in terms of the first step we did the first 2 months, which was to contain the virus, which was social distancing. The second 2 to 12 months was in testing, and this is where we are at. Testing, contact tracing, isolation. We need to do that until we finally do the ultimate goal, which is a vaccine or a treatment. What are the metrics that we follow? And these are really important to think about. And I believe that every city is looking at this. The first and foremost, the number of new cases. If you look at in America today, we have the highest number of new cases. And so each city follows that path. Then the second is your hospital census. And this arrow shows that our hospital census, this is our local Memphis data, is going up. But that doesn't decide everything. What you really need to see is your capacity of the hospital and the ICU, as well as your testing and tracing capacity, because that is what is going to determine if you're going to be able to remain open. No one has an appetite any longer to close up again. So what we must do is maintain the hospital capacity and the ICU beds, as well as the testing capacity. So what to open and what not to open. The way you decide that is based on these 4 criteria. This is from the Hopkins guidance document. First, look at if, for example, what is the contact intensity? How closely people are getting together. At churches, there's a lot of contact intensity. People hug and kiss. Contact number. How many people are there at a given event? So, for example, at a ballpark, at a fair, there's a high contact number. Duration of contact. How long will you be there with somebody? And lastly, modification. Can you wear a mask? Can you keep your distance? And all of those will determine if an event or an activity has the risk. And with these criteria, we decide one event by another, one category by other, which will be remaining and closed. We're making these decisions on a daily basis. How to open, there is no question, and this is probably the single most important slide for you to remember, is the impact that distancing and masking makes. This is from Lancet, June 1st, and what we know is social distancing 3 meters reduces your risk. This is a meta-analysis from 12.8% down to 2.6%. So literally a 6-fold decline in your risk of transmission. This was SARS, MERS, and COVID. But look at the masking. They went down from 17.4 to 3.1%. So a huge impact with the masking and distancing. If there was any set of numbers that you want to remember and tell your colleagues who are deciding not to mask, say your risk of transmission goes down from 17% to 3%. So all of this in reopening, there's an element that we need to use and understand that's going to be for testing and for tracing. I'll speak a few things about testing, and there are 3 types of tests we know quite well. PCR tells us about the current infection, the antibody passed, and the antigen is just getting developed, and it tells you about also the current infection as well. In the PCR test, which is the gold standard, there are several ways of doing it. The standard is 1-to-1. However, we can reduce the cost and increase capacity by something which we call pooling. That means taking multiple samples, putting them in one. Your lab needs to get an EUA, emergency use authorization, to make that work. And that's really important to think about that strategy. How to do the testing? There are multiple ways. The classical has been the nasopharyngeal. That's like the brain biopsy one. You really don't need to do that. The sensitivity and specificity through IDSA, pretty good with mid-turbinate. That's what I would recommend for anyone who's symptomatic, and then those who are asymptomatic, you can go and do a nasal swab as well. Lastly, thinking of how we're going to open up schools. This is going to be really difficult. Let me tell you why. Imagine a city school that has 100,000 kids in it. That's what we have. In the general population, even a conservative estimate is 0.3% of the population is positive and asymptomatic. We did our firefighters just last week, asymptomatic, 1% positive. 100,000 kids would lead to 300,000 students, 300 students from 100,000 students who are positive. If each one of them infects 5 to 10 other kids in school, which you know they will do, you have very quickly 1,500 to 3,000 infected kids. It will not be easy, let alone possible, but we will see what time will tell. Last two slides. What have we learned from the past? So this is what happened in 1918. What we saw was in Philadelphia, they did and delayed the lockdown. And what you saw was a huge surge that killed over 250 deaths per 100,000. St. Louis, in contrast, did social distancing early on, lockdown, and they saw what we call the dampened curve. However, you open that up and you see a second wave. In fact, what we're seeing not is the second wave quite yet. We are barely going through the first wave in many places. And then what will happen next, we really don't know, but this is what I say and I do know. The uncertainty of what will happen is not about the virus. Before we learned, we know so much about it. The uncertainty is not about the virus, and the virus is unpredictable, but because human behavior is so unpredictable. So with that, I will finish. Thank you so much for giving me an opportunity to share ideas on this. Thank you, Amit.
Thank you, Manoj. That was a wonderful talk, and city of Memphis must be proud of you for keeping them safe. Next, we have Jayanta Mukherjee, Jay Mukherjee. He's an advanced imaging cardiologist at Ohio Heart and Vascular Physicians in Columbus, Ohio. And he's going to give his perspectives on how to cautiously get back to business in the cardiovascular imaging. So we have got two cardiologists today. One would be talking about imaging, and I'll introduce the next person after that. So we'll have two perspectives on cardiovascular. One is on imaging. Jay, please take over.
Thank you. Can you see my screen? Okay, can you hear me? Can you hear me?
Yes, we can hear you very well. Go ahead.
All right. Thank you, Amit. Thank you, Api. Thank you, Dr. Reddy. Anupama, it was a great time meeting everybody and creating this presentation. So I want to basically talk about the imaging world and basically, during the pandemic, the utilization of cardiovascular imaging decreased by almost 50 to 90%, with shift in certain modalities, to conserve PPEs and to lessen exposure to healthcare professionals. So now when we are thinking about reopening, and every society and multimodality societies are coming together to create some kind of guidelines how to do it. I would just focus on this one table, which was actually in the pre-publication mode in JACC cardiovascular imaging, which is giving us the whole idea of every modality in the cardiovascular world, imaging world. And you can take that to other radiological imaging like CT and MR. So I would like to start on the transthoracic echocardiogram. I'll go over each of these separately in separate slides. And I would leave the confirmed COVID cases on the right column a little later on, and just focus on the no symptoms suggestive of COVID-19, because we're trying to reopen and go forward with our business. So transthoracic echocardiogram, they're recommending a mask along with gloves and face shields. I'll go a little more detail about exercise stress tests, and then go with the transesophageal echo. Now, the transesophageal echo is really aerosol generating, and that requires the highest protection in the form of an N95 along with a face shield and a gown and everything else. And people who cannot use N95 will need to use a PAPR. So I'll go one by one and come back to it. Just a take-home message will be this slide. So basically, transthoracic echocardiogram, or you can say ultrasound in regular world, and this will probably apply to most surgical procedures if you're doing it before your surgeries. Most common test performed, and in the hospital setting where the suspicion is pretty high, in the ICU setting, we're still using or recommended to use a point of care ultrasound or limited transthoracic echocardiogram. What about in the outpatients? So the outpatients, we had a long debate. We have 100 cardiology group and many medical directors. We sat down and talked, what do we do? Because as you see, the sonographers, healthcare persons are very close to the patients for 45 minutes doing this study. So do we expose them? Do we risk them? But eventually the guideline came out. What we are doing is similar to what we are kind of doing it. We are screening the patients at least twice, once a day before and on the day when they come in with the same CDC questionnaire. And then on the day of the test, they get a mask and a temperature taken. And both the sonographer and the patient is both wearing a mask. And then the study is completed. So basically, these patients do not need to be tested for COVID-19 if they come as an outpatient. Now, inpatient, we are testing everybody who comes down the door in the hospital. So now let's go to the next procedure, which is a transesophageal echocardiogram, which is very highly aerosol generating. Same thing as intubation, same thing as bronchoscopy or any endoscopy procedure. Dr. Sudhakar will talk to you later on about. And till now, this was not being done until we really thought it was absolutely indicated. Now, since we are reopening, we were doing kind of other imaging modalities if we could. Since we are reopening, we have to do some of these tests anyway. But again, for these tests, even as an outpatient and inpatient, we are mandating everybody to get a COVID-19 test 24 to 72 hours prior to the test. And after that, we are asking the patients to stay quarantined. Even after the test is completed and they're COVID negative, really, we are not thinking about doing this test in COVID positive patients yet. We haven't really faced that. Once these tests are negative, the whole team is following a complete PPE schedule with the N95 and a face shield and everything. So that's, as the disease wanes off, we gradually open up more and we'll do more of these tests. But till now, we are strictly following these, which is kind of managing with the guidelines. Now coming back to the stress test modalities, the different modalities, I won't go into details, but basically when you're ordering a stress test, especially, in the surgical world, pre-op evaluation, think about pharmacological stress test. That is much more safer than an exercise stress test. So these are the images of those. I'll go over what are, based on the safety for viral transmission to the staff. And again, this is not just, between you and the patient, it's all about everybody around us. So we want to make sure, because if one person in our lab gets infected, that can asymptomatically spread to other person. So basically, PET imaging study has the best shorter duration and less contact with the patient. So that one we were trying to do. People who do not have PET in their facilities can think about doing a regular D-SPEC, which is very widely available everywhere. And, especially with the stress first protocol, we are doing that a lot now. Shorter time frame, get the answer, and it's still good. And next comes abdominal echocardiography. I don't go into the details of that. The exercise stresses are towards the end. We were not doing it at all for the 6 weeks during the pandemic. Now, since we are opening up slowly, we are slowly doing them more. But the main catch to this is all kind of exercise testing, EKG, SPECT, everything is we need to get tested, just because with exercise, there's a high risk of aerolization because patient is breathing fast. And if somebody's asymptomatic, can really spread the virus pretty fast. So anybody who is needs an exercise stress test, needs to get tested for COVID-19. We are going a step forward and we are testing for anybody who is coming down the door for a stress test, even a pharmacological or exercise, we are testing them for COVID-19. So that's the take-home message from a stress test perspective. Many people probably are ordering stress tests for your patients, prior to surgeries or in their offices now. So if you don't have the testing capability available right away, think about a pharmacological stress test. You can get the answers and get the work done. If you have testing available and you want to get the exercise capability and stuff, get a COVID test and then do a stress test. Okay, so that's basically about the stress test modalities and different kinds. Again, it may be differing between different places where the prevalence of COVID is high or low. It may differ on that. But again, the take-home message, exercise, consider order COVID-19 testing before the exercise stress test. The last modality I would like to talk about, the cardiac CT and MRI. And again, this will probably go for any kind of MR or CT you're ordering for your own patients in different fields. So this has the least risk. And we really did not stop these modalities completely. Even through the pandemic, we were doing it with cautions. And now since we are opening up, our schedules are probably up to 80-90% filled with this. So just because, less contact with the patient, but we are still screening them very meticulously. Again, all the inpatients are getting COVID-19 testing admission who comes through the door. All the outpatients are getting screened twice, a day prior and day of the study with same questionnaire. Temperature taking, mask mandatory for the patient and the tech. Everybody is keeping that distance. And meticulous cleaning in between the studies. And that's the reason we are not able to go back 100% because, we need more time to clean the places, ask the questionnaire and all that. So again, back to take home message is this table, this slide, which you can apply to any imaging modality, not just cardiovascular. I'll run through that quickly and briefly. CT, MRI, less risk, mostly droplet and contact. Just a mask and a glove is good for you and the tech, and the distancing and the meticulous cleaning and hand washing. The stress test pharmacological is still less risk, same kind of protective equipment, mask and a gloves. For a transthoracic, the society is recommending a face shield for sonographers. We haven't done that, but we are trying to implement that because it's tough to have a face shield and scan the patient 45 minutes. For exercise, any kind of exercise stresses or where the patient is going to breathe faster and all, think about N95s, face shields, gowns, and all kind of stuff because there's a high possibility of aerosol generations. And the T, again, in invasive procedures, same thing like endoscopies or bronchoscopy or intubation, same thing. Even if they are COVID negative, even if they have tested, you have to test them first of all. And even if they're tested, you have to think about complete full PPEs for long. So this is probably my second last slide. Luckily we in Ohio, we have probably passed the peak. We don't know whether they're going to get the peak again or not. And so we're thinking of gradual resumption of all our imaging services. And we're doing it cautiously. As I discussed, we're following that meticulously. And hopefully we'll stay like that. And I'll end that with that. Thank you, everybody. I'm happy to answer any questions in the end.
Thank you so much, Jayanta. That was a wonderful talk. And then we'll have another cardiology perspective from Dr. Indranil Basu Ray. He is a consultant cardiologist and cardiac electrophysiologist in Memphis, VA, and a medical center adjunct professor at the University of Memphis, Tennessee. And Dr. Basure has spoken widely. He actually gives a lot of talks everywhere regarding this topic. And he's going to talk today on how to open up cardiological procedure in the post-COVID era. So Dr. Basure.
Hello, everybody. Good evening. Thank you, Anupama and Amit, for having me. So today I'm going to talk about the different cardiovascular procedures and what we do now that we are planning to open up. As you know, there are a few million people in this country who get a heart attack we call STEMI, which requires primary angioplasty within the 90 minutes by the time they enter the gate of a hospital we inflate the balloon. So the good news is that in my talk today, I'm going to divide it into three different parts. The first part, I'm going to talk about the interventional procedure, which is STEMI, non-STEMI, and UA, which is part of ACS, acute coronary syndromes. Then I'm going to talk about the structural heart disease procedures like TAVR, mitral clip, left atrial appendage closures, and then finally I'm going to touch base on cardiac electrophysiology procedures like ablation and devices. So good news about cardiology procedure is, unlike what I hear from other specialties, every hospital has their own rules, regulations, but in general, for cardiology procedure, all over the world, there is similar concepts starting from Canada, America, India, China, Europe. They've all come with a single guideline. As you can see, I couldn't get all the organizations in one slide. So all these organizations came together to come to a consensus, and that's what I'm going to speak about today. So yes, as I said, what we call ST elevation MI or STEMI, a few million patients in US itself, presenting in a year, couple of thousands every day. So these are people who tend to die if they're not immediately treated. So what the cardiology committees have done is they have divided the opening at 3 levels. Level 2 is when hospital allow reintroduction of some services. Level 1 is where there's reintroduction of most services, and level 0 is as good as a regular service that is in the pre-COVID era. Now, a little more understanding what these 3 means. So regular service means you're having ongoing COVID testing on every patient. You have appropriate PPE, and all the patients as well as the physicians are appropriately tested based on their requirements. Level 2 service means the super urgent service, the emergency service, super urgent service, emergent service are all allowed, but stable service and non-emergent service are on hold. Level 1 is you're allowing emergent, you're allowing urgent, you're also allowing certain stable services that can lead to mortality or morbidity if you hold back. And obviously level 0 means as good as pre-COVID era, as long as you're doing COVID testing. So for STEMI, which as you know has a high mortality rate, during COVID, we were trying to get the primary angioplasty was reduced, and some people were even getting, even in places which could do primary angioplasty, they were getting thrombolysis. But in level 2, every patient gets primary angioplasty. Now, there's difference between all the other procedures that I'm going to talk to today and STEMI. The reason is, as you know, by the time a patient comes into the hospital, balloon needs to be dilated in his blocked artery within 90 minutes. So we don't have the time to do even an urgent stat COVID test. Stat COVID test in most of the hospitals in Memphis takes almost 1 to 1.5 hours, some hospitals even 2 hours. So when you have to put the balloon up by 90 minutes, there's no way you can do a COVID test. So a lot of these people, there's no way to know if they have COVID other than asking questionnaires. But questionnaires are also dicey because STEMI people can get fever also. So so you have to have appropriate PPE, and in rare cases, in most cases, you don't need anesthesia. So there's no physician who are like extremely close to the patients. But taking appropriate precaution, most people can get STEMI. In level 1, everybody will get treated for STEMI because of its high mortality. Obviously in 0, again, everybody will get treated for STEMI. And now there's some indications that people, vessels other than the blocked vessel may need angioplasty. That's what you're not going to do in level 2 and level 1, but you will start doing at level 0. Now for non-STEMI, the story is different. Most non-STEMI may not need, does not need PCI urgently, and PCI can be done later on after 8 hours, 10 hours, 12 hours, particularly if they're high risk. If they're not high risk, they need medical management. So at level 2, Only the high-risk patient, people with heart failure, people with significant LV dysfunction, people with hemodynamic instability, they are the ones who will get PCI. But remember, PCI is it generally gets delayed in NSTEMI. It's not urgent. So most people, at least in our cath lab, everybody gets a stat result of COVID before they're taking into the cath lab for a PCI. In level 1 patients, the medium risk patient, that is patients who don't have any one of these, like heart failure, instability, refractory symptoms, even they can be taken in if the important vessels are at risk, for example, LAD, which might have more mortality, plus like people with diabetes, mellitus, multiple comorbidities, even they can be taken. In level 0, as you can see, routine service. So there's basically no difference between the COVID era and non-COVID era as it was before. You make sure that everybody gets every patient gets COVID-19 testing, appropriate PPE is available, and you take every patient to do it. Now, the next part of my talk is a little more complex, but I'll try to make it as short at the same time as succinct as possible. So on the top of what I have is the structural heart disease and some EP procedures. So structural heart disease, the common structural heart disease for most places, including my hospital and most of the top centers in this country, and a large number of private practice is getting TAVR done. So TAVR, the only indication for doing TAVR in stage 2, which is almost we are going to stage 1 now, at least in my hospital, but a lot of hospitals are still in stage 2. Only severe symptomatic patients, whether inpatients or outpatients, you do TAVR. Now, most TAVRs are actually done as an observation because patient comes in the morning, gets TAVR, stays throughout the day, goes back the next morning if everything looks okay, getting an echocardiography. But unless they develop some complication like heart blocks and stuff like that. So only patient with severe symptomatic aortic stenosis, that is having heart failure, severe refractory chest pain, or passing out, which is syncope, they get TAVR now. In stage 1, most patients will get TAVR other than completely stable cases with no symptoms, but severe aortic stenosis who do need TAVR. Other than that, everybody will get. And in routine, once you come to 0, everybody gets a TAVR. For TAVR also is, however urgent it is, all patients coming to the cath lab get tested even today, that is in stage 2, and the same will be followed for stage 1 and certainly for stage 0. Mitral clip, it's little different. There also it's severely symptomatic, but people with mitral regurgitation can have different level of symptoms. So it's somewhat dependent on how severe the mitral stenosis is along with symptoms. Like you might have mild to moderate with severe symptoms and severe mitral stenosis with almost no symptoms. So based on that, patients are going to take it. So basically patients with the worst mortality, like stage 3 or 4 mitral regurgitation who are severe symptomatic or in refractory heart failure, they can be taken in stage 2. In stage 1, most people can be accepted by the cardiac team. Again, stable patients should be deferred for routine services, which will be available in stage 0. In ASD PFO, there is really no cases which are really urgent or super urgent unless somebody has developed stroke, multiple strokes, and has got an ASD that needs urgent closure or has got a DVT that can result in a stroke. In those cases, you might do it, but classically, it has been left empty by the guidance board because there's really hardly any case which is emergent ASD closure. Left atrial appendage closure, the same story. There's hardly anybody who is who needs urgent or who needs emergent. There are certain urgent cases like people who have had strokes, have atrial fibrillation, liable to develop massive atrial fibrillation, might have had just a TIA now. But those people who cannot be given any blood thinners, in those cases you can give. So it's mentioned as selective cases. Once we reach stage 1, then majority of the cases can be done. And again, for stable cases, we wait for routine service. Now, going to the EP procedures, ablation, any pre-excited AFib, as you know, it can cause death. Any AFib with recurrent admission, there are AFibs, we have 5, 6, 7, 10 admissions a year with severe refractory heart failure. Those AFib need to be ablated. And drug refractory VT, so most VT, which are ischemic or non-ischemic, tried on a drug, failed on a drug, getting beaten up by the ICD, those are the cases you have to take in stage 2. And majority of the rest cases of VT and AFib can be taken in stage 1, other than extremely stable cases. I don't think anything in VT really comes under really stable cases, because somebody has VT that itself can cause sudden cardiac death. So, but yeah, AFib, which are stable, you can wait, you need to wait. Routine service, again, is when you can do everything in that.
Dr.
For
Basura,
devices,
just last slide, please.
Yeah, this is my last slide, actually. So for devices, we have been doing pacemakers throughout the COVID era because they are complete heart block, and you continue to do the same in stage 2. Along with secondary prevention and primary prevention ICD, which we have not been doing during the COVID era, that has been added. And for stage 1, majority of the case, both ICDs, BIVs, and pacemakers to be done. And again, in stage 0, routine service, just like anything else. So core thing is every patient coming to the cath lab does get a COVID testing done, and appropriate PPE is made available to all the operators. And remember, for electrophysiology procedures, all the procedures, rather most of the procedure has anesthesia on board. They're done under general anesthesia, just like surgery. So it's not only the cardiologist, but the EP, but all the anesthetist is also involved in these procedures. Thank you very much for having me. I'd love to take questions whenever those come up.
Great. Thank you so much, Dr. Basurai. And that was the topics are vast. We have got the fortune of having so many good speakers, and all of them are in our panel. And I wish we had more time, but basically all of us will be available at the end. And also, please, if you have any questions, please type those questions. Next, we have elective endoscopy during COVID in ambulatory surgery center. The speaker is Sudhakar Jonalagadda. He is a gastroenterologist and a transplant hepatologist and the director of Coffee County Center for Digestive Diseases. So here is Sudhakar, who is also the president-elect, becoming the president in a few more days.
Can you see my slides, Amit? Amit, can you see my slides?
Yes, sir. Go ahead.
Thank you very much, Amit, for a kind introduction. And thank you, Dr. Reddy and Aurora, for giving the opportunity along with the esteemed speakers. My task is today to talk about GI endoscopy practices in COVID-19, particularly gastroenterology perspective. Is not going forward? Okay, thank you. The top priority is the safety of the patients and the staff, and all the patients should be screened pre-procedure within 72 hours of their visit and update as needed responses. And staff should be screened every working day, check the temperature, history of any exposure, all kind of stuff. And use a non-contact infrared thermometer should be considered. And always practice proper hygiene when putting on or taking off PPE. Distancing and PPE is very important. Distancing and PPE considered in the endoscopy center. And the pre-admission staff should wear a surgical ear loop mask, nitrile gloves. And I'm sure everybody don't have ample space, but physical barrier is very important. The plexiglass partition should be considered if sufficient physical distance cannot be accomplished. And clean and disinfect the device used for checking, and discourage any device that aren't easily cleaned. All the staff should wear N95 respirator equivalent could be considered. And the patient should come by themselves or with only one essential family member or caregiver, and they should wait in the premises or vehicle until they've been called for the visit. And all the check-in process should limit direct contact with the staff and place patient immediately in a room after screening. And all the patients and staff should wear a washable cloth mask at all the time. What you do in endoscopy center? The pre-admission staff should wear a surgical earlobe mask, nitrile gloves, as I mentioned before, and nitrile gloves, N95 mask, and gowns. Scheduling process, document the patient procedure tier in the telehealth, most in tier 1, tier 2, tier 3, and patients should notify the practice of any changes in condition that may occur between scheduling and data procedure. COVID testing, a significant number of COVID-19 infections are being transmitted by asymptomatic or pre-symptomatic individuals, and all the tests, all the patients should be document presence of antibody before the procedure, that is 48 hours before the procedure, and the PCR should be done before the case. What you do in endoscopy center during check-in process, upon arrival, all the patients should have a COVID-19 questionnaire, should be repeated, and temperature should be taken. And cell phone numbers of the patient and family should be recorded and questions answered. If feasible, patient should be waiting in the vehicle or premises until notified to come to the building. And all the patients should proceed directly to the preoperative bay. Family members wait in the vehicle. A space of the chairs in the waiting room, face masks worn by all the family all the time. For insurance verification, payment should be handled remotely if possible. What you do in the preoperative postoperative rooms process, patients should be admitted directly to the rooms, and patients should continue to wear face masks. And most importantly, procedural oxygen mask, if you use, should be replaced with oxygen mask immediately after the procedure is done. And notify the family member when a patient is ready to discharge. And discharge discussion can be proceed with the appropriate distancing measures, and follow-up phone calls will be made as per the policy. All the patients should notify the office of any fever. This is generic questioning, everybody repeating irrespective of the specialty. Cough, shortness of breath, sore throat, loss of smell or taste, nuance of fatigue, nausea, nuance of diarrhea, or any other significant new unusual symptom should notify to the office. In procedure room, members of the endoscopy should wear PPE, including gowns, gloves, hair covers, eye protection, and should wear N95 mask or equivalent. If patient requires nebulizer treatment administered, they should be done in the procedure room rather than a pre and post-op room. Metered dose inhalers are preferred over nebulizers. The cleaning, there is no recommendation for changing cleaning process. Most important thing, Clorox bleach wipes should be used for kitchen and personal desk spaces. Restroom should be cleaned frequently, ideally after each patient, since they all come for the colonoscopy, they use bathroom. And there are no terminal cleaning procedures recommended at this time regarding disinfecting the endoscopy. This is the mask as FDA approved and recommended for endoscopy. It has the two ports. One is the nasal and oral port, and it can measure the capnography. The visualization of the mask is very good. It costs about $25 to $30, but not paid by the insurance. But it is benefited if you use one-time use, and most of the physicians can recommend in ambulatory surgical center. Thank you for the attention, and happy to answer the question. Thank you, Amit.
Great, perfect. Thank you so much for that wonderful talk and keeping it short and sweet, and so that we can have multiple answers, question and answer at the end. Next, I'm very fortunate to introduce to you somebody to give an ENT perspective. He's also from Long Island, His name is Dr. Rajesh Kakani. He's the chief of otolaryngology in Mercy Medical Center, Long Island, New York. and he's the vice president of Long Island Society of Otolaryngology, head and neck surgery. So Dr. Kakani is going to give us the ENT's perspectives. Again, like I said, we have concentrated on the people who are most at risk from getting back to practice in the post-COVID era. Dr. Kakani.
Thank you so much, Amit, and thanks to API leadership. Thank you for allowing me to present. Those were wonderful talks, but I want to remind you that the coronavirus does enter through the nose. So our specialty is a special crosshair of this thing. To keep in time, I'm going to focus on 2 or 3 key areas. The main thing was the loss of sense of smell and taste. This has been one of the very early symptoms, and it usually recovers in several weeks. There are no randomized controlled trials about proven treatment. But even before the COVID, ENTs are used to treating anosmia secondary to viral infections, and these guidelines are saline sprays, maybe steam inhalations, vitamin B complex, and oral prednisone. If the problem persists, we do a CT scan of the sinuses. The second thing that we ENTs interact with COVID is the need for tracheostomy. And a lot of these people eventually need tracheostomy, and it's an aerosol generating procedure. And the question is what precautions we can take in doing the tracheostomy. So the question is, do we do it bedside or do we do it in the operating room? And in general, everybody thinks the operating room is safer. Do we do a traditional open tracheostomy or a percutaneous one? And here the answer is whichever one the surgeon is more comfortable with. What special tricks would you do to prevent exposure of the staff and the surgeon? So what we are doing is we are advancing the endotracheal tube down to the carina so that the cuff is below the level where we would be making the opening, as opposed to normally when we do a tracheostomy, the cuff is above the level where we make the opening in the trachea. And this hopefully prevents the exposure of the staff and the doctor. The other issue is the office considerations. I mean, ENT, after all, is the primary care for ear, nose, and throat. And we are all primarily more busy in the office. We get exposed in the office, and our academy has been amazing in providing support and guidance in terms of how to open and how to be safe. And the thing is, we have to be aware that all PPE are not equal, and some of the PPEs that were being sold and supplied were primarily meant for construction work. So people have tried to innovate masks and other face shields. And Dr. John Alagadda showed us the mask that the GI use for their procedure. There's one of these masks, Envo mask, in which there is like a cartridge of a filter so that you can change the cartridge and the mask is much more comfortable. Some people have tried to design a mask in which there is an opening to pass the thin scope, kind of similar to what Dr. John Alagadda showed, and there are other variations. And then there are some people who have designed face shield and masks to protect the surgeon. I will try to show you one of those in a minute. And the last consideration is when you really know it's a COVID positive patient and you have to use the drills and stuff, what precautions we use, and PAPR has been a gold standard. The problem is with PAPR, you cannot wear a headlight. We ENTs are used to operating in a tunnel and we need a headlight very often. So PAPR is not with its own, issues. The issue to decide is to do it in the office or in the operating room, and most of us are choosing to do more things in the operating room compared to what we would do in the pre-COVID era. And as Dr. Sripad explained to us that, there are lots of grids from various organizations, including ACS, about classifying patients in terms of emergent versus urgent versus time sensitive and routine. At least in New York area right now, we are doing all cases. There is no restriction on the cases. But if there is a resurgence of cases, maybe, we will have again a little bit of rationing. So if you allow me, I would, of course, take questions at the end. If you allow me, I will try to share a 2-minute video with you. Let's see, how do I do that? Okay, let's see. Okay, hang on 1 second, allow me. So okay, share, and okay, this is a 1-minute 26-second video. Need to wear magnifying glasses, also known as loops, especially ear, nose, and throat surgeons need to wear magnifying glasses when they do surgery. So I have a simple modification to the face shield. What we do is we take a regular face shield, mark 2 openings to allow these loops to get through, and we make the hole using a disposable knife. This way the surgeon can wear loops as well as the face shield. Good. This is how the surgeon can see a magnified view yet be protected. So since I recorded that video, now I actually only make an X-shaped incision into the shield rather than an excision of a piece, and that opening fits relatively tightly. Of course, I cannot say it will protect all the viruses, but it is better than nothing if you have to get exposed to the. Thank you for allowing me to present this data, and I would be happy to take questions. Thank you again, Amit, Sadaka.
Thank you. Thank you, Dr. Kakani. It was an excellent presentation. Love the video. I was getting a smile on my face when you showed that. So we're going to introduce our last speaker. I think it's going really good, and truly appreciate every speaker maintained their times, and the slides worked excellent on time. No waste of time today. So I'm going to introduce our last speaker, Dr. Amit Chakravarti. He is CEO, President of Poplar Bluff Urology. He's current Board of Trustee, API, and he's our incoming Secretary of API. And Amit will talk on practical tips for the practicing physician, COVID-19 medical practice reopening checklist. Thank you, Amit. Stage is yours.
Thank you, Anupama, and thank you, Suresh, for asking us to do this thing, and a wonderful panel of speakers. You did a great job, and most of all, thank you. After 3 months, I've worn a tie and a jacket, though I'm wearing a short, but at least Uparka, thanks a lot. This gives me a little, anyway, so thank you very much. Today, what I'm going to talk about is how to, let me just share my slide for a second, and I hope you guys can see my screen. You guys can see my screen?
Yes, Amit, we can see you.
You can see me, but I want you to see my screen. So
Yeah,
that's what
I can see.
No, we can see your screen.
Great. Okay, good. Thank you.
Go for it.
All right. So today I'm going to talk about COVID-19 medical practice reopening checklist. So this is, everybody has spoken about their own perspectives, own specialties, but I'm going to speak about generally what we do in different aspects. So basically the key items we want to address is to ensure the practice, the state's locality gating criteria. In other words, some states are allowing opening much earlier. We had in St. Louis, in Missouri, we had openings much earlier. We actually, they allowed for big meetings also, but some states, obviously, they are staggering it late. And some states were, after opening, as we know, are going back to getting back to their partial lockdown stage. So also you determine the services you'll be able to perform safely within the clinic, and some things we can not do safely, or or because of the patient's safety, you would rather him not come to the office and get exposed, like elderly people, people with other problems. Those patients can be handled by telehealth. Also, you need to determine the necessity of care bed based on the clinical needs. And we've already talked a lot about priorities of surgical procedure care, doing high complexity, real important cases. It's a double-edged sword these days, I always tell you, because on one hand, if you tell them that, hey, COVID, we cannot do this, he might, especially I've raised this point about a person who needs angio, you just don't want to do it, and you say that, hey, we'll just wait, and the patient dies. What do you, are you liable of not doing it? So what we do is that we have got a special consent form, which you tell them that, look, this is a semi-elective case, or this is your urgency, but remember, you are exposed, you are getting yourself exposed, coming to the hospital, you have to make the informed decision. So, and you have to make sure that you have got a good supply of PPE. What employees should expect? They should not be complacent. The physical distancing should continue. I have got my office space, which I have spread it out, and I'm fortunate that I've got a corridor which is really, you know, like mine, kind of exclusive. So I put my some chairs outside. So we have a distancing, and those things should continue. Masks in the office and in presence of patients should continue, and all of regular and frequent cleaning of all surfaces, like we used to do. We used to clean all the doorknobs, tables after each patient's. We continue to do that. What's important I want you to bring is that I've sent a lot of emails to membership regarding practical tips, and most of these emails were on financial management. So I want you to, there in my website is amitapi.com, and go to the blog, and all those things are available there on all the things which the government has rolled out in face of this. A lot of things are old now. We have already got advantage of that, but right now, is coming up the PPP loan, which you have been given. You know that you have to repay that, or you have to not repay that, sorry. You have to make sure that you give it to the patient. Initially, they said that we had to give 75% for the payroll protection plan, so 75% for the payroll and 25% on overhead of other, you know, rent and utilities, etc. Nowadays, they have made it 60 and 40%. So now you can use 40% towards overhead, paying back whatever needs to be done. Collection activity, we had actually put a stop on collection activity when all this was happening. All the patients who actually were receiving bills, we had temporarily stopped sending those bills. Now we should resume them. Now you also accept, determine how you accept patients' payments. Usually patients used to come, give their credit card or check, and now you should actually set up some online payment portal like PayPal or something else where they can pay online rather than having to come just to pay their bills. You share your volume forecast to the ancillary staff, saying that, look, we're not going to ramp up right away, but we might ramp it up. So these are the, you know, in next month, we need this, next month we need this, etc., etc. So, and then resource management or workforce, you need to see if anybody had been laid off, you want to bring him back. There are people who got laid off and were very happy to be laid off during that time, or they called themselves furlough. There's a difference between furlough and laying off. Furlough means you still are in an employee but don't get paid. In that case, you get paid from the government, and a lot of my employees were very happy to do that because actually they're getting paid more than they were when they were working. What's more important in this slide, I want to bring it, that you need to know about the billing updates during COVID. During COVID, there have been several codes which have been instituted during the COVID period. One is telehealth, telemedicine, telehealth, and they have waived a lot of this. You don't have to be HIPAA compliant with the telehealth services or telemedicine services. And now they've even dropped the video They say that in rural communities where you don't have internet, you cannot get video, you can charge, and there are different codes. That's a different topic altogether. We did that talk last time. If you have those, if you want, that's there on the previous talk. You can go to API website and find out. Bottom line is that you need to educate your billing people, if you've got your own billing staff, that this can be done these days very easily. For example, if you're at home and your patient has been admitted to the hospital, you can do a teleconference, and there is the codes are just like that. Telemedicine, which is video and audio, you charge exactly like an E&M service and base it on the level of service. Telehealth, which is just audio service, there are different codes for it, but the reimbursement has come to be almost equal to the E&M service. Rest are all the same. If you have an elderly office employee, you might like her to not come in during this time. So those are the things. The operational management, you need to, I've already talked about preparing the waiting room, physical separation, sterilization processes, maintain equipment, scheduling blocks. All these things are just practice. Evaluate your telehealth procedures. A lot of people were on telehealth, but now you may like to have them come back, not the full amount. Maybe you see 1/4 of your quota of patients so that you don't have your waiting room full. You just cut it down to 1/4 and see 3/4 on telehealth. So slowly you can get back patients, but make sure that they are not lined up. Also, another thing, what you can do is tell your patients not to bring their relatives or friends with them. Let them come alone. A lot of times we have also told them that, hey, listen, when you are here, just come and sign up and go and wait in your car. We will call you when it's your turn. If there's a delay, you just wait in your car and we'll call you back. So those are the things which we can do that. And these are local health department reporting guidelines. You need to find out whether you have COVID patients. How do you report it? Do you report it to CDC? Do you report it to the government agencies? And Manoj gave a good and he's the person to go to regarding that. There are websites where you can find out how obligated you are to actually tell people about all these guidelines. But more importantly, there are patient educational materials which are available. I put some posters on the waiting room itself for patients to know what they need to do to keep themselves safe, etc. Most people know ad nauseum because it's been on TV over and over again, but give them some educational materials. They don't know some stuff. They need to know these things. And I told you about how I handle visitors. This is my last slide, and this is the most important slide I think everybody should know. We do a lot of telephone, teleconferences or what do you call telemedicine, telehealth on video. So this is how I put together a tele-etiquette. This is my slide called tele-etiquette. You have to have an etiquette, do's and don'ts of telemedicine. So you need to have a non-distracting background. In other words, try not to have a whole set of books in your background, which a lot of us like to do. Have a lot of nice books. Patients are now reading the titles of your books behind you and not concentrating on you. It's much better to just have a bland background and just speak to the patients. Number two, you have to do it in private without any distractors. Your mobile phone should be turned off. Most importantly, you should make sure that you don't have any other patient's information lying on your desk. For example, there's a file folder here and it shows the patient's name. You need to make sure that be very cognizant of the fact that you do not hide those patient information. If you are at home, make sure you go to a separate place, close the door, because there's HIPAA compliance. You don't want your family members who have not signed a HIPAA waiver to hear what you're talking about. And it's particularly important in my specialty, if you know what I'm talking about. Again, dress as a physician is always very easy to just wear your t-shirt and talk to the patient. Just make sure that you do it just like as if you are in the office. You can wear your scrubs and a jacket and a white coat, or you can wear your tie, or you can wear whatever you would wear in the office if you want to see patients. Very important. People don't understand that. You think that patients are at home and what's the harm in having them wait for half an hour, because they don't have anything anywhere to go. It's not like they're waiting in my waiting room, they're doing their stuff. No, the patients may have to pick up the kids from the school, drop off somebody else, go to the grocery store. So please be on time, because being on time is equally important when you're at home doing telemedicine as you are here. Review your charts before the visit so that you actually don't look at the computer and reviewing the charts while they're on the thing, because you need to look into the camera while doing visits. Don't look at the screen, because if you look at the screen, your eyes are not on the patient. You're not talking to the patient. If you're looking at the screen, and this is how different this is. I'm looking at the screen, I'm looking at the camera. If you look at the camera, that means you're talking to the patient. That's the reason you should review the chart earlier. Yes, you can occasionally look down and look at some results, but most importantly, that's another thing you need to do. No multitasking. You cannot answer your face WhatsApp while you're talking to them, and text messages, etc., etc. Another important thing, do not eat or drink during the interview. It's very, very easy to have a drink and munch a sandwich or have something, but you should not do that, because this is again a professional call. And also at the end, ask if they have any questions. And most important, at the end of the thing, because this is a new concept, this is something new, ask them, hey, what do you feel about this teleconference? Do you like it? Is there anything else you think I should add? And there are a lot of telemedicine things coming up. Doximity is one, which is made by a physician. It's free and it's absolutely HIPAA compliant. And it's what I use it's on your cell phone, and it's very, very easy to do. And I use that. But ask them about their feedback. Do they like it? Some people say that, doximity has been very easy. One touch and they can do it. But still, there are older patients who I have in my practice who cannot even do that, and that's something which you need to be be cognizant about. So thank you so much. I really appreciate you listening to me. I hope we learned something.
Thank you, Amit. That was pretty useful information. We have hardly 3 minutes left for Q&A, so I'm going to ask the question now.
Yes.
Dr. Mukta Gupta, any idea how long insurances will continue to pay for telemedicine, like until fall or winter? Amit, you can answer the question.
Can you just, I got a text from the hospital. Just shouldn't be multitasking. Can you repeat that real quick? Sorry.
Any idea how long insurances will continue to pay for telemedicine?
So this is going to continue, and it all depends on how we contain COVID. But I have asked this question several times. There is no end in sight right now. So you will be doing telemedicine and telehealth, and there's a likelihood that this telemedicine and telehealth going to continue. They'll make some restriction, they'll make some HIPAA restriction, they'll make some a little bit more restriction, but it'll continue, most likely.
No, I think, the telephone consultation, they're not paying. They're paying only for video consultation.
No, Sudhakar,
I think they're paying for both.
They're paying for both. Audio only also they're paying. There are codes. I have given the code list. It's on the API website. Please go and check it out. There's a different code for that. The video and audio, you charge just like E&M, okay?
But I think it's still till the July 26th is for confirmed, and after that it'll probably prolong.
Yes, that's true.
Thank you so much. And the next question is, I don't know how relevant it is to our topic. Can we do lactose, lactulose, and fructose breath test? So Dr. Kakani, maybe.
No, I'll take the question. I'll take that, because
That is
he's talking about the bacterial overgrowth and lactose intolerance, fructose intolerance. Somebody came with abdominal bloating. It is a difficult question because of this. They had to use a disposable mouthpiece to blow into the machine to see, whether it is intolerant to lactose or fructose or bacterial overgrowth. So I think I'll hold off, until we have some kind of guidance right now. We don't have any guidance on this. But use in office lactose, fructose. But I'm doing case by case because we are testing those patients. If you're negative, we are doing okay. We have to ask the patient, if you want to do this, you have to do the test before you do this test, So that's why we are going right now in office. But again, it is tricky. Yeah.
Thank you, Sudhakar. This last question before we wrap up. In the office setting where we don't have any means of sterilizing the N95, can we just hang it for 7 to 10 days and then reuse it, assuming virus will be dead? Yes, we can do that. Or we can also do 30 minutes steam, under steam, in your home. You can put it in a steamer and then you can steam it and reuse it right away. You don't have to wait until 7 to 10 days, or you can keep it in your oven 77 degrees. So that's the last question. And I would personally thank every speaker today for excellently manage the time, and the slides and everything went flawless, and thank you so much. And we have a program coming up now at 9 o'clock. I think we all will say goodbye for now. Let us enjoy these two great singers for tonight from India. You will love it. And thank you so much. And I would have either Seema Arora or Dr. Suresh Reddy, if they are on the to say thank you to the speakers.
Yeah, thank you, Anupama. So that was a very educative talk. I really enjoyed learning about the science of reopening. It's such a nice way of putting it, opening up the offices, testings, elective surgeries, and all the procedures. And the telehealth and telemedicine part was very practical. So I hope, the human behavior will, like they said, will define the future. So I hope people keep following all these precautions. So thank you very much to all the speakers, Dr. Shripad, Dr. Manoj Jain, Dr. Mukherjee, Dr. Sudhakar, Dr. Kakani, and of course, Dr. Anupama and Dr. Amit. And thanks for organizing this very informative webinar. I invite all of you to join the concert now. It's relaxation time always, 10 o'clock. And that's a stress reliever for us. Thank you.
Thank you. Thank you so much.
Thank you so much, everybody. All panelists did a great job. This was an awesome conference. I really appreciate all of you working hard.
Thank you. Good night.
Good night.
We're going to disperse.